So, good evening, everyone. I am Dr. Avneet. I am DM in pulmonary medicine, critical care, and sleep medicine, and I am presently working as assistant professor in Adesh Medical College in Department of Respiratory Medicine. So, before starting with my talk, I just want to pay my sincere thanks to the organizers of this NEPICON 2021 2021, who gave me an opportunity to deliver a lecture in this prestigious national conference. So my topic of discussion is interventional pulmonology and overview. So I have no conflicts of interest to declare. So this is the outline of my presentation. So this will be a case-based discussion. So we will have 6 cases. I have tried to cover all the most common presentations that we encounter in our OPDs or IPDs in routine, like a case with the consolidation, a case with central lung mass, a case with peripheral lung mass, a case with mediastinal lymph nodes, a case with ILD, and a case with pleural effusion. So we have 6 cases, and then we will see how we need to proceed in these cases with respect to the interventional pulmonology. So just to start with, we have some available and usually performed diagnostic modalities in pulmonary medicine, just namely flexible bronchoscopy. Through flexible bronchoscopy, we can have a ball, we can have a bronchial aspirate, we can have endobronchial brush, endobronchial biopsy, transbronchial biopsy, and conventional TBNA and EBNA. So then we have EBUS TBNA and EUS BFNA, we have radial EBUS, we have rigid bronchoscopy guided biopsy, we have cryoprobe TBLB, we have thoracoscopy. So these are the main modalities that as a pulmonologist we use in interventional pulmonology. And other than this, some are used by the radiologists and the surgeons, like mediastinal VAD, surgical lung biopsy, or ultrasound CT and PET-CT guided biopsy. So if we discuss what are the advanced pulmonary interventions, then we have too many, like the navigation bronchoscopy, either it can be VBN or EMN. It can be high magnification bronchoscopy, narrow band imaging, and autofluorescence bronchoscopy. Other than this, we have robotic bronchoscopy, ultra thin bronchoscopy, ocular coherence tomography, and among the therapeutics ones, we have the bronchial thermoplasty, we have the bronchoscopic lung volume reduction that we used to do in AIIMS New Delhi. But for this lecture or for this presentation, I will just stick to the basics of the pulmonary medicine so that even all physicians and all the practicing doctors can have some benefit from my lecture. So now we are done and we will start with the case 1. So case 1, here we have a 42-year-old male with no drug addiction, history of diabetes there that was uncontrolled, and he was symptomatic for last 1 month with the complaints of cough, aversion, dyspnea, easy fatigability, loss of appetite, and loss of weight. So he was, sputum analysis was done, it was inconclusive, MON2 was negative, he received 2 weeks antibiotic outside, but there was no response. So this is the X-ray of that patient, in which we can see that we have a right upper lobe consolidation and with probably cavitation in that area. So the CT depicted the same right upper lobe consolidation with cavitation. So how to proceed in this case? So what is the next investigation trial? Whether we should go for CT guided biopsy, or we have option of bronchoscopy with bronchoalveolar lavage, that is BAL, or we can go for EBUS TBN in that case, or we should go for bronchoscopy plus biopsy. So let's try to find out the answer. So just before going into the details, we need to have a quick review of the basics. Like we have 2 lungs, very simple, right lung and left lung, and each lung has then 3 lobes. Like the right lung has 3 lobes, right upper lobe, middle lobe, lower lobe, and left lung has 3 lobes, left upper lobe, lingula, and left lower lobe. Although the left lingula doesn't has any independent bronchial supply, left upper lobe and lingula has the same bronchial supply. So after the lobes, we have then subsegments. On the right side, in the right lung, there are 10 subsegments, and in the left lung, there are 9 subsegments. Subsegments means like in the right upper lobe, We have three subsegments like right upper lobe apical segment, right upper lobe posterior segment, right upper lobe anterior segment. In right middle lobe, we have two subsegments like medial segment and lateral segment. And in the right lower lobe, we have again five segments like superior segment, medial segment, anterior segment, lateral segment, and posterior segment. All these are posterior basal, lateral basal, anterior basal, and medial basal and apical segment that we have in the right lower lobe. So right upper lobe has three segments, right middle lobe has two segments, and right lower lobe has five segments. It is the largest lobe, so it has the five segments. And same, almost same goes with the left upper lobe lingula and the left lower lobe. Although left lower lobe, the sub segments are five, but there are some anatomical variations also sometimes. So on a chest X-ray, we can have a very fair idea that it's the right upper lobe, it is the right middle lobe, and it's the right lower lobe, left upper lobe, lingula, and left lower lobe. So if we have something on the chest X-ray, any lesion, then we can make it out very easily that whether it is in the right upper lobe, middle lobe, or the lower lobe. Or sometimes we use the word actually Jones on the chest X-ray. Other than this low prediction, we can have sometimes a fairly idea that in which subsegment it can be there in the right upper lobe, whether it is in the right upper lobe posterior segment, whether it is in the right upper lobe apical segment. So we can have some fair, a rough idea sometimes. So to be very definite that where the lesion is, then we have the option of CT. So in the CT, we can precisely localize that where the lesion is present in our in the CT, like whether it is in the apical lobe, whether it is in the right upper lobe posterior segment, or anything. Like here, if we start the CT reading from upward downward, we can see that we have the apical segments, and then we have the anterior and posterior right upper lobe segments. Then we have the right middle lobe and lateral and right middle lobe lateral and medial segment. Then in the right lower lobe, we have five subsegments, and same goes with the left side. So with the CT, we can easily have a precisely have an idea that where is the lesion in which lobe and in which subsegment. On the X-ray, we can have idea in which lobe, and we can sometimes have a rough idea that that can be the subsegment also. So via bronchoscope, what we do? So we just introduce the bronchoscope via the nares or by the mouth, and then introduce into trachea, and then goes into the bronchus, main bronchus, right main bronchus, and right main bronchus and left main bronchus, and then we proceed into the various lobes. Like this is the trachea. We introduce the bronchoscope into trachea. Then this is the right main bronchus, and this is the left main bronchus. Then we went into the right main bronchus. Then we went into right upper lobe bronchus. This is the right middle lobe bronchus, and this is the right lower lobe bronchus. In the right upper lobe, when we enter, we can go into right apical segment, right posterior segment, and right anterior segment. Means with the bronchoscope, we can go into the trachea, then the main bronchus on the both side, left side and right side, and then we can go into the bronchus of the lobes, like the three lobes on the east side. Then we can go into the each segment, like we discussed the 10 segment on the right side and 9 segments on the left side. So what is the significance of this? So means why we have discussed so much. So like first identify the lobe. You can identify it on the chest X-ray, and better to be on the CT. Then identify the segment, obviously better on the CT. Then we introduce the flexible bronchoscope. Then we go into that segment and then wedge the scope into that segment, and then we take bar. What is bronchoalveolar lavage? How we do it? We just instill some saline and then suction that. So that saline will have secretions from that infectious etiology or whatever it is along with it, and then we can analyze that ball for gram staining, culture sensitivity, fungus, Jaden staining, CB net, cytology, or anything else that we are suspecting. So this is called bronchoalveolar lavage. So in our case, our diagnostic modality of choice will be bronchoscopy plus ball. So means bronchoscopy ball is primarily useful in various infectious etiologies. Like we are suspecting some bacterial pneumonia, we want to find a causative organism, or we want to find it whether it is fungal pneumonia, like the pulmonary mucormycosis. We do just do diagnose it with bronchoscopy plus ball. We can have a diagnosis of TB, pulmonary TB, drug resistance or drug sensitive or drug resistant, or anything else. All these infective etiologies are very much can be identified with bronchoscopy plus ball. So in this first case are diagnosis or investigation choice is bronchoscopy plus. So just quick with the second case. So in the second case, we have a 59-year-old male smoker, symptomatic for last 4 months, cough, congestion, dyspnea, and associated consistent symptoms. On examination, there was nothing. Chest examination clear, and FDG PET CT showed FDG mass. So in this case, we have a mass, and this is the central mass. So it is just in the right hilar area. And when we did the CT, there was a right low mass surrounding the bronchus and invading the bronchus. And on FDG, there was a FDG with mass on the PET CT. So what should be our next investigation in this case? Whether we should do bronchoscopy plus biopsy or bronchoscopy plus endobronchial biopsy or brush or bronchial aspirate, or we should go for CT biopsy, or we should go for flexible bronchoscopy plus bronchial washing. So let's find out. So in that case, we did a bronchoscopy and then we found some endobronchial lesion. So this is not the image of the same case, but here we can see some endobronchial lesion. So in the patients who have central lung masses, and on the CT scan, we can have a very good idea that we can have endobronchial lesion, irregularity of mucosa, or there can be endobronchial growth. Then we do bronchoscopy. In bronchoscopy, like we have found some endobronchial mass. So what we will do next? We will take biopsy from that mass. So this is endobronchial biopsy. So is that all? No. So we need to take some other things also, like bronchial washings. It is just like the bronchoalveolar lavage. We will put some saline here and then we will just suction it out, and then we will send it for cytology for malignant cells. Then we have a bronchial brush also. So this is the brush. We just rub it here, rub it here, rub it here, and then take it out and then just make the slide from that material. So we need to do endobronchial biopsy plus brush plus bronchial washing if we found something endobronchial in a case in which central mass or suspected malignancy. So there is a literature behind that if you only go with endobronchial biopsy, then the sensitivity is only 74%, means diagnostic yield is only 74%. And if you combine it with the brush and the bronchial washing, then your diagnostic yield increases to 88%. So in this case, we have the diagnostic modality of choice is flexible bronchoscopy plus endobronchial biopsy from the endobronchial growth plus bronchial brush from that area and bronchial aspirate from that area. So in the third case, we have a 27-year-old male. He is IT professional, no past history of ATT, no previous comorbidities. He was referred from an ophthalmologist and diagnosed with anterior uveitis right eye, and he was referred just for the evaluation of that. There was no respiratory complaint and MON2 was negative. So on the chest X-ray, we can find there a mediastinal lymph node. So then we did CT, and on the CT there was clear-cut large mediastinal nodes. So what is the next investigation choice? Whether we should go for EBUS TBNA or we should go for conventional TBNA, and what is the difference between conventional TBNA and EBUS TBNA, or whether we should go for bronchoscopy plus BAL and biopsy like we did in the earlier cases. So let's solve this thing. So we did flexible bronchoscopy. There was no endobronchial abnormality. Like in the last case, when we did bronchoscopy, there was endobronchial growth and we did some biopsy and other things. So what to do now? We have no endobronchial growth and we can't take BAL because this, if you see this growth is not in the lung. This is the outside the lung, in the mediastinum. Mediastinum is something different from the lungs. I can't take BAL from here. And when I introduced the scope in the bronchus, there was no endobronchial growth. So it is outside the bronchus. So how to sample it? So this we can see. So from by the bronchoscope, we can go into trachea and then right main bronchus, left main bronchus, right lower bronchus, and then left main bronchus. But this is outside the bronchus, like here, like here, like here. So how to sample it? For this, we have a EBUS scope. So what is EBUS? It is just like a bronchoscope, but here we have a ultrasound, dedicated ultrasound, and here we can have a needle through from the working channel, and we can put the needle into some lesion we want to sample. So this is the ultrasound probe. We can on the ultrasound, and this is the needle. So how we do it? Like this is the trachea. We introduce the bronchoscope here, and here we switched on the ultrasound. ultrasound, with ultrasound we can make out that there is some lesion. This is a lymph node, and then from this scope working channel we can introduce needle into that lesion and can sample it. So it is the real time sampling of the mediastinal mass or lesion with EBUS. So this is how it in the real looks like. It is the mediastinal node, and this is the needle. We introduce the needle into the node or mass, then we sample it, and then we send the samples for cytology. Also, we also take biopsies. It is called float core biopsies. It was particularly done in the AIMS. So it is both ways. It is very helpful for the diagnosis. So, like we introduce the bronchoscope here. We just on the ultrasound, and we are able to see all around. So we can just make out our lesion, and then we can introduce the needle into the lesion in the real time via EBUS. This is the one thing. So like if we don't have the EBUS, then what to do? So then we have the option of conventional TBNA. So what is conventional TBNA? That we do with the bronchoscope, simple bronchoscope. Like we introduce the bronchoscope here, like we did the EBUS scope. So here, reaching here, we will just give a blind puncture here, just examining the CT that the node is here, node is here, node is here. So just with estimate, we will put a blind puncture here and sample the thing. Like this is the epistibian node and real-time puncturing. This is carina, left main bronchus, right main bronchus. Here, subcranial node, we put a blind, we put a needle blindly, just with the estimation that below this there will be the lesion. So this is called conventional TBNA. So conventional TBNA can be helpful if the mediastinal node or masses are particularly large, but it has a lesser yield for diagnostic efficacy than EBUS TBNA due to obvious reasons, and it has a high complication rate because in the mediastinum we have a large vessel, we have the aorta, we have the superior vena cava, we have the heart. We can introduce the needle wrongly into some blood vessel. We can introduce the needle wrongly in some heart chamber. So if we have the EBUS TBNA is the modality of choice to sample the mediastinal nodes or mediastinal masses or to make the diagnosis. So is that the new toy in the twine or need of R? Yes, it is the need of R. EBUS TBNA should be considered as initial diagnostic modality in evaluation of mediastinal nodes and for diagnosis of sarcoid, tuberculosis, lung cancer diagnosis, and staging, lymphoma, and fungal infection. So in here in Adesh Bhatinda, we did 21 EBUS in last 3-4 months. After having that score with us, adequacy of material was 100% and diagnostic efficacy was 90%. And the most common diagnosis was surprisingly lung cancer in 35%. And sarcoidosis in 30%, tuberculosis in 25%, lymphoma and fungal infection is 5%. So it was TBN is a modality of choice if you are having some mediastinal node or mediastinal mass or some mass that is surrounding the bronchus or central airways that can be sampled with the EBUS TBNA, and if we don't find anything endobronchial. So in the this is the next case 4. So in case 4 we have a 41-year-old male with ILD, diffuse ILD, and he's not responding to our treatment. So we want to see what are the other options. We want to see what is the type of that ILD because he's not responding to options. There is no symptom to suggest any connective tissue disorder. There is no symptoms to suggest any HP. All our diagnostic investigation serum and other things were normal, and he's not responding to our and our usual therapy. So we want to make the diagnosis of what type of ILD it is. So what we have the option. So whether we should go for BAL, whether we should go for BAL plus TBLB, or we should go for BAL plus cryo-TBLB or surgical lung biopsy. So let's solve this question. Actually, the BAL has a very limited role in the ILD. Just to mention a few, like in the hypersensitivity pneumonitis, if in the BAL, you take BAL from that area or from the area with the most involved area. If it is more than 60 different lymphocytes, then it can clinch the diagnosis of HP and some other diseases like eosinophilic pneumonias, tropical pulmonary eosinophilia, lymphangitis, carcinomatosis, asbestosis, lipoid pneumonia, or DH. We can have a diagnosis of that disease via BAL only, but it has a very limited role. Otherwise, we should do biopsy in ILD. We have the option of TBLB, surgical lung biopsy, and cryo-TBLB. Because in the ILD, we need lung biopsy. So what do we have the option? Either we can do it by the bronchoscope like the TBLB, or we can do it open like the surgical lung biopsy. So how we do it by the bronchoscope? We introduce the bronchoscope in the trachea, and then we introduce it into the right main bronchus, like right lower bronchus, and then the subsegment, and then we introduce this probe. This is the biopsy probe. This is the biopsy probe, and this biopsy probe is advanced up to the end, and then we open it, and then we take the biopsy from the most distal area, and it is a lung biopsy. The only issue is that probe is so small, the size is so small that the piece will be a very smaller size, and sometimes it can not give diagnosis. And if we compare the TBLB with the surgical lung biopsy, that is the open lung biopsy, then TBLB is primarily helpful if the disease is centrally located, centrally like around the this center part, trachea, bronchioles part, and and otherwise the surgical lung biopsy the choice. In the case of efficacy, there was a systemic review by Duria et al. It was seen that the diagnostic efficacy of TBLB was 56% only, whereas compared to the VATS, that is the that is done by the surgery people, they were 92%. So TBLB efficacy was 56% only. But the other thing that with the VATS and the open lung biopsy, it is not easily available. It has a very high complication rate. It is very difficult to just make the patient to undergo that investigation that has a very major complication, major morbidity and mortality, a significant mortality rate also in these investigations. So what we have the other option is that the end of story? No, we have a cryobiopsy. So in the cryobiopsy, the limitation of TBLB that it just takes very small sample. It is overcome by cryobiopsy. So what is cryobiopsy? So here we have a cryoprobe. This is a cryoprobe. What we do, we just introduce it into the lung, into subsegment, and then we freeze that area, and then we take it out. So with the cryoprobe, we have a significantly large lung pieces from the lung, and the complication rate of cryobiopsy is significantly less than the open lung biopsy or VATS carrier biopsy, and we can have a we can clinch the diagnosis. And this is again by Dr. Duria et al. A systemic review where he found that the efficacy of both the surgical lung biopsy and cryo TBLB or VATS carrier biopsy were comparable to each other. So in the case 4, we did BAL plus cryo TBLB, and we clinched the diagnosis of NSIP pattern. We changed our treatment, and patient responded to that. So we are just running out of time. So just quick case 5, we had a fusion that was right side of fusion, and it was tapped outside twice, but diagnosis could not be achieved. So we can see pleural nodules here in the fusion. Then we did this thoracoscopy. So in thoracoscopy, just like we introduced the chest tube, we introduced the thoracoscope, and where we can see the pleura and we can see the pleural nodularity. We just take biopsy from these nodules, and then we can send them for the histopathology and can clinch the diagnosis. So thoracoscopy can be done when there is rectal fusion, or there is a fusion that on just a tapping or pleural fluid diagnostic pleural fluid analysis, the diagnosis is not clear. So in the last, just a quick 2 slides for a last case, that when we have a peripheral mass, what can be the options? So in the peripheral mass bronchoscopy, there will be no endobronchial lesion, BAL was not helpful. So what are the other options? We just need to know we have one thing also, radial EBUS. Earlier we discussed it was convex EBUS. Here we have a radial EBUS. With the radial EBUS, we can go into the periphery, just on the ultrasound, and in the periphery we can find the lesion, and then we can sample it. It just looks like that. So this is a lesion. We went into the periphery with the radial probe, then on the ultrasound. So this is the lesion, and then we sample that lesion and can clinch the diagnosis. If we compare with the CT guided biopsy, its yield is definitely less than CT guided biopsy, but the complication rate is very less than CT guided biopsy, and it is a worth try in particularly selected patients. So in the case 6, we did a radial biopsy, and the radial EBUS biopsy showed lipidic adenocarcinoma, which was initially was suspected to be a pneumonia or just bacterial pneumonia. So my take-home message that a thorough assessment of clinical radiological profile must be done to choose appropriate diagnostic modality. Flexible bronchoscopy plus BAL may be appropriate in most of the suspected infectious etiologies, and IBUS TBNA remains the investigation of choice for mediastinal lymph nodes like in tuberculosis, sarcoidosis, lung cancer, and lymphoma. and TBLB is usually preferred over open lung biopsy in most of the ILD cases wherever tissue diagnosis is needed, and medical thoracoscopy remains investigation of choice for undiagnosed pleural effusion. Irritabilis can be a modality to diagnose peripheral lung mass lesion in particular selected patients. So thank you, or thanks a lot.